Hello, my name is Dr. Michelle Marie Peña, and I'm a neonatologist at the Children's Hospital of Philadelphia and the Hospital of the University of Pennsylvania. Thank you for the opportunity to present to you today on the equity-focused quality improvement framework. I have no relevant conflicts of interest to disclose. So today, the objectives are to define equity-focused quality improvement as a framework to address disparities, describe concepts of the EFQI framework, and share best practices in applying EFQI to real-life work. To get us started, I wanted to share a definition of health equity. This was published by the National Academies, where they define health equity as the state in which everyone has the opportunity to attain full health potential and no one is disadvantaged from achieving this potential because of social position or any other socially defined circumstance. Quality improvement interventions have the potential to improve disparities and further health equity. However, this requires explicit attention. So if you look at the example chart displayed, you can see that there is an improvement in this measure over time. Here, displaying the outcome in aggregate may show the overall improvement, but whether there are disparities between different groups remains unknown. Looking at stratified data, you'll soon see how quality improvement initiatives may affect an existing disparity in 3 different ways. It may improve outcomes for all populations evenly. However, the disparity can persist. It can improve outcomes for all populations, but with greater improvement for the group that's not experiencing a disparity. So this can further widen the existing disparity, as shown here. And lastly, it may improve outcomes for all populations, but with a greater improvement in the group that's experiencing the disparity, decreasing the disparity. Because of this, quality improvement initiatives without an explicit attention to equity risk worsening existing disparities or even generating new ones. This brings me to equity-focused quality improvement, or EFQI. EFQI are QI initiatives that integrate equity throughout the fabric of a project. It's inclusive and collaborative, and it prioritizes and addresses the needs of disparity experiencing groups. This differs from QI with an equity lens in that it's action-oriented and it's completely centered around equity. Equity is central throughout the project from the very beginning, not post hoc. EFQI principles are applied at every stage. We define EFQI and share best practices in our manuscript in seminars in fetal and neonatal medicine entitled Using Rising Tides to Lift All Boats, using equity-focused quality improvement as a tool to reduce neonatal health disparities. I'd like to spotlight my co-authors, including Dr. Reichman, Dr. Braccio, Ms. Madu, and Dr. Montoya Williams. The work I'm sharing with you today is not my own, but the output of a wonderful collaboration with the authors listed. I'll also supplement the discussion with some real-life lessons learned. Also, while the title specifically mentions neonatal health disparities, these concepts and the best practices that I'll share can be adapted to address disparities in patients and families of all ages. I've linked this paper here with the QR code shown. I'll spend the rest of this presentation sharing the 8 concepts described in our manuscript. So before I start, I want to acknowledge the diversity of the audience that's listening to this presentation. You all work at different institutions, clinics, and units with different specialties, different practice focus, with differing resources. And you're all serving different populations and different communities. And each of these have different lived experiences. So as I review these 8 concepts of EFQI, I'd like to invite you to think of your clinical practice and how these principles could be adapted to your setting, your hospital, your clinic, your unit. The goal is that hopefully you can take at least one or two concepts back with you and take action locally. So to start an equity-focused QI initiative, it's critical to foster a culture of equity in your local clinic, unit, and hospital. This framework by Dr. Chin is one of my favorites, and it's helpful because it shows concretely how to move from talking the talk to walking the walk when it comes to a deep, genuine, and intentional commitment to equity. One quote from the article says it clearly: well-meaning intentions will not take an organization far unless accompanied by concrete actions. You can see at the top, to commit to a mission of maximizing the health of diverse individuals and populations. In other words, to intentionally advance health equity, you have to create a culture of equity, where biases can be both identified, both on the individual and system levels. You also need to implement a roadmap to reduce disparities, which includes identifying disparities, carrying out root cause analyses, and implementing interventions. These are all critical components of the equity-focused QI framework we're discussing today. To do this, you need buy-in from all people in your system, from those on the front lines to those in leadership, so that everyone can operationalize advancing equity into their daily jobs. To further this concept, we advocate that equity be given as much value and priority as safety, to the point that we think of equity as everyone's work. We think of this as a culture change, where equity is operationalized and embedded into all work, into all our practices, policies, guidelines, job descriptions, and every initiative that's carried out. And this needs to be built in a sustainable way. To do this, as I mentioned, you need buy-in from everyone in your system, especially leadership. This requires genuine openness and humility to critically evaluate systems for discrimination, racism, and bias. An explicit commitment can further help this work, as it serves to make equity a priority worthy of investment. While calling out systemic racism and bias is a critical first step, investing in investigating and improving systems and processes requires resources, including effort and time. Those leading EFQI efforts need protected time and funding to do this work, including the time to start new initiatives, collect and analyze data, understand your context, as well as tailor interventions to local subpopulations and collaborate with multidisciplinary teams. So now to our second concept. To address a disparity, it must first be identified. Looking only at aggregate data, as we saw earlier today, can be misleading, and there may be undiscovered, buried disparities that you'll never know about if you don't look. So to start, we recommend stratifying existing QI measures by selected progress plus variables, and I'll go through these in a moment. You can also start a new EFQI initiative with a disparity-sensitive measure. This is defined by the National Quality Foundation. You can identify a disparity-sensitive measure by thinking about measures with a known disparity, measures of care decisions that are impacted by provider behavior and discretion, communication-sensitive processes, and measures that are impacted by social determinants of health. Data can be stratified using real data, so by race, ethnicity, and/or language at the very least. You can also stratify by other socio-demographic factors, like the progress plus variables. Progress is an acronym that stands for place of residence, race, ethnicity, culture, language, occupation, gender, sex, religion, education, socioeconomic status, social capital, and other. The plus stands for personal characteristics associated with discrimination, features of relationships, and time-dependent relationships. To start, look to see what data are currently being collected either through your electronic medical record or other mechanism. It's also important to investigate how these data are collected. For example, how are race and ethnicity collected in your hospital system? Is it collected by a person or is it filled out in a form? Is it self-reported? What options are available? How often is it missing? These data can be quite limited and are often inaccurate, so it's important that you understand your current state. In fact, if these data are inaccurate or missing in your system, you can potentially work on improving the process to make it more reliable to yield more accurate data. Next, incorporate equity into every stage of a project, from your problem statement and smarting to your family of measures, your root cause analysis, your countermeasures, and your PDSA cycles. The key to doing this is to remain intentional about integrating and centering equity. This means discussing it and taking it into account at each stage. Concept 4. Families and community partners are critical stakeholders to make your work patient and community-centered. To do this, we recommend ensuring that families and community partners have a seat at the table. This can be an incredibly collaborative relationship. They can provide input on project design and validate your framework and priorities. They can help strengthen and sustain successes and help you better understand failures. And it's important to remember not to assume that you know what families and communities know or need. The voice of the patient is needed to make sure that you're designing initiatives around patients' needs. There's so much to learn, so we recommend leading with curiosity to learn from families and the expansive work that's being performed by community coalitions. When incorporating families and partners, we recommend that this be done in an intentional way. Teams should create a welcoming, safe space for families and partners so that they feel comfortable sharing their experiences, their perspectives, and their opinions in a way that makes them feel listened to and respected. Compensation is an important part of this relationship. For example, in a working relationship with community partners, it's helpful to start discussions with asking how you and your team can help further their mission as an organization. Sometimes the ask can be as simple as sharing a flyer with patients about their support group. Other times, it could be other partnerships or collaborations. It's also important to compensate them for their time and expertise because they're so valuable. You can consider an hourly rate, paying for parking, or providing food as well. Qualitative methods can also be a helpful way to include the patient family voice. This can be done through focus groups, interviews, and surveys. In my experience with our incredible community partners, they've enriched our work and our thinking with their perspective, experience, and expertise. They've been a powerful, respected voice in discussions around racism and bias, and they've helped us stay centered around the patient. Next, consider alternative comparator groups. So by definition, a disparity is a difference between at least two groups. Historically, white patients have been the comparator group, as white patients typically make up the largest group and have long been considered the historically advantaged group. In EFQI, we challenge you to think about the reference group based on specific criteria, such as the size of the group, largest group, for example, or performance, like the highest performing group. With this, the comparator group may differ depending on the measure. You can also compare data across units, with similar hospitals, or with using data from regions or at the state level. In thinking about measures, you can look at raw stratified data, or you can track the disparity gap between groups, or even a ratio that's comparing the groups. One word of caution, if you do choose to look at a difference or a ratio as part of your operational definition, Be sure to still look at your raw data, as you want to make sure that you're not seeing an improvement in a disparity or ratio because the comparator group performed worse. The goal is for everyone to improve, with a targeted improvement in the disparity experiencing group. Concept 6. Focus of work should be on evaluation of root causes and the modification of systems and processes. Language matters in these conversations. In looking at stratified data, we don't want to other groups of patients or label certain groups as more or less advantaged. So it's critical to have a frank conversation about what terms you're using and what they represent. For example, when talking about race, remind the group that this is a social construct and a proxy for racism. You can use your QI tools to structure your evaluation of root causes. You can use driver diagrams, fishbone diagrams, and 5 whys, for example. It also helps to focus the conversation on modifiable systems and processes rather than individual behaviors. It's not about blaming patients or a group of patients, but rather thinking about racism, bias, and social determinants of health in our healthcare system and processes, specifically thinking about policies, guidelines, and practices, and how these are implemented inequitably in our systems. These conversations can often be challenging and uncomfortable, but they're necessary to address inequities and to create a culture of equity. Here you can see a driver diagram for one of our projects looking at breastfeeding inequities, which is quite complex, as you can see. I wanted to specifically highlight our primary drivers. Through the process of creating this driver diagram, we had frank conversations evaluating our hospital system and our care models for bias and racism with all of our stakeholders, including our community partners. You can see here for our primary drivers, we included racism and bias in our hospital system, in the prenatal care setting, and in the postnatal care setting. We have social determinants of health included, support, as well as previous and historical experiences. I will say that acknowledging and calling out racism and bias in our organization was a crucial first step in our work. Here I show the same drivers from our driver diagram in a fishbone diagram. You can see the conversation can be framed using categories like hospital and clinical setting, including specifically the environment and culture, processes, patient and family factors, community and historical context, and resources. Next, for concept 7, adapt existing visualization tools to emphasize disparity trends over time. The goal is to present data to clearly communicate observed disparities over time. This can be done with stratified charts or disparities dashboards, which are built to automatically stratify data and allow you to surveil for disparities and track disparities over time. And lastly, approach dissemination of data from an equity perspective. Patients and communities should have access to knowledge that may impact their healthcare. This is important as we think of patients and community coalitions as partners and not subjects. To do this, disseminate your work with communities and organizations using plain language summaries. This can be done using lay media or social media. And then lastly, in thinking about publishing QI initiatives, we encourage that publication guidelines, including SQUIRE, the standards for QI reporting excellence, include equity as an integral domain. It's also critical that QI leaders share details on their context to help with generalizability and adaptability. So this concludes our whirlwind of EFQI concepts. Again, to review the concepts I went over. 1, foster a culture of equity. 2, to address a disparity, it must first be identified. 3, Incorporate equity into every stage of a QI initiative. 4. Families and community partners are critical stakeholders. 5. Consider alternative comparator groups. 6. Focus of work should be on the evaluation of root causes and modification of systems and processes. 7. Adapt existing data visualization tools to emphasize disparity trends over time. And 8. Approach dissemination of data from an equity perspective. I hope that from this talk, you took the following points home. QI without an intentional focus on equity can perpetuate, worsen, or improve inequities. Equity-focused QI centers equity in project design and may effectively address inequities. Important EFQI principles include stratifying data, collaborating with family and community stakeholders, and focusing on modifiable systems and policies. I'd like to end with a call to action. Start your EFQI project by stratifying an existing QI measure or identifying a disparity-sensitive measure. Thank you for the opportunity to share our work and for your time and attention. I've included my contact information on this slide. Again, I'd like to acknowledge my co-authors, Dr. Reichman, Dr. Braccio, Ms. Madhu, and Dr. Montoya Williams, who are major contributors to this work. I have provided the reference and our QR code to our article again on this slide. I look forward to our next session. Thank you very much.